Good morning. I'm Laura Diolasi, the Executive Director of Milken Institute's Asia Center. Welcome to the 11th episode of the webinar series, The World Post-COVID-19. Today's episode will focus on health tech innovations, building health tech-infused healthcare systems for a post-COVID-19 world. And it will be moderated by Dr. Jeremy Lim, who's an Associate Professor and Co-Director of Global Health Program in the Sosweek Hawk School of Public Health at the National University of Singapore. We have three amazing panelists today. Jeff Chan, who's the Group Chief Innovation Officer of Fullerton Health. Jonathan Larson, the Chief Innovation Officer of Ping An. Ingrid Li, who's the co-founder and chief scientist iCarbon X. They were China's first biotech unicorn. The world of the Milken Institute falls under two categories, health and finance. Our work in finance is to bring investors, financial services leaders, and policymakers to talk about issues shaping the global agenda. Our work in health focuses on accelerating cures and speeding up the process of finding cures and treatments. Today's webinar falls right in the middle of those two discussions, two topics. One of the silver linings of the COVID-19 pandemic, if there can be a silver lining to a pandemic, is the acceleration of acceptance of digital innovations. So health tech has the potential to support and complement struggling healthcare systems and amplify the reach of doctors and of medical solutions. Our three speakers today are going to talk about what's happening on the ground during COVID-19, but also talk about the future, how health tech can transform our futures in the way that we live and get medical treatments. Now, without further ado, I would like to pass it on to Jeremy. Thank you so much, Jeremy, for moderating our 11th episode.
Yeah. And thank you very much, Laura, and a very good morning to all of you who are in Asia. It really has been said that at the highest level, health systems are very straightforward. All of us want low cost, high quality, and universal access. So it's really cost, quality, access. And COVID-19 has really forced us to catalyze this move towards virtualization. Maybe can I start the ball rolling with really Jonathan? And could you share, based on your experience with really Good Doctor and with the other platforms that really Ping An has been involved in, what are you seeing? And how are consumers and really providers embracing this?
Well, thank you, Jeremy, and thank you to Laura and to the Milken Institute for including Ping An in this dialogue. Finance and health are indeed our two areas of primary focus, so I think we have a great alignment of interests. So to Jeremy's question, I think this has been obviously a traumatic period for many individuals and for many economies, and we're by no means through this at a global level. But the China experience has been quite interesting. So we've had Good Doctor in place as a telemedicine platform. It's basically a primary care consultative platform with an automated triage layer, and then the ability for patients to interact with our staff doctors and indeed third-party doctors remotely via that platform. We've had that platform in place now for about 8 years. We took it public in Hong Kong in 2018. Today it has a market cap of about $14 billion. And I think while it had grown extremely well, it got to about 300 million users by the end of last year. The acceptance of telehealth, it's been a work in progress. And I think that we've certainly seen COVID be a catalytic moment for telehealth in general and for Good Doctor in particular. And just, I've got it's a listed company, so I can't just give statistics that are not publicly disclosed, but things we have disclosed publicly in our sort of earlier earnings release this year. So covering the sort of January and to mid-February period in China, which was indeed the peak of this in China, we had, in the space of about 3 weeks, 3 to 3.5 weeks, we had 1.1 billion visits. We had 10 times the increase in registered users, and we had 9 times the daily rate of interactions or consultations with patients. So it's really transformed the user base and the level of engagement. And we think that is going to sustain. We think that once people understand that they don't have to wake up at 6 in the morning, show up at 7, and spend half a day in a state hospital waiting for 3 minutes of consultation time, and being shunted from department to department, where you can actually do a lot of what you would have done in that physical context remotely. We think that that's going to be a permanent change. Very interestingly, in the China context, China, of course, is a largely state-driven health system, and the state health insurance program pays for a little over 50% of all health expenses. Very interestingly, up until now, up until recently, we've relied not at all on state reimbursement. But as a consequence of COVID, Hubei province, which is where Wuhan, which was the original epicenter of COVID in China, has now started reimbursing telemedicine consulting and consultation. And that's probably something that will expand to the rest of the country. That is a really significant shift. And it is in line with the government's own plans to, over time, introduce telehealth to China in a systematic way and make it part of the health infrastructure of the country. But I think it's a really a watershed change. So I think that what the context of this in China is that China spends today about $700 a year per capita. Obviously, that's unevenly distributed given the disparity of wealth across the country. The US, as we know, spends about $11,000 a year, and countries like Germany, Australia, UK, Japan, that's somewhere in the zip code of $4,000 a year. Whichever way you look at it, China has an enormous challenge ahead to calibrate its health system to global standards. And that probably can't happen. It's probably not affordable for that to happen fast enough if China goes down the path that the West went down. So we think that technology is going to play a fundamental role. We equally think that for developed economies, many of the same solutions will actually be enablers for reining in the costs of the healthcare system. Mm-hmm. I'll just mention two other things. We think of sort of the 3 layers of how the health system might transform. The good doctor level is an example of the kind of health system infrastructure level. And good doctor can ultimately become a health record center. It can become a payment platform, or many other things as well, and certainly a data platform. But at the point of care, we're seeing a lot of good innovation as well for being able to do simple blood tests, for example. Even we've got technologies that are emerging now for being able to do viral identification, even for COVID. So the world doesn't yet have a low-cost handheld device that allows you to do a COVID assay and get a result in 10 minutes, 10, 20 minutes. Those technologies are now emerging. So that's something that we're very focused on. And at the other end, so you think of the sort of user interface or the point of care, you think of the infrastructure, there's an intelligence layer as well. We're finding that using artificial intelligence in particular, for particularly visual analysis at this point, to be able to, for example, take the retina of the eye and analyze it and use that for diagnostic purposes. We have a company we've invested in called AirDoc in Beijing, and they can identify 30 disease types from a single scan of your retina. And applying the same technology to X-rays, CT scans, for example, we're able to identify lung cancers and many other abnormalities from visual data. So some of these technologies are really coming into their own. So we see transformation through technology and through new business models at multiple levels.
Yeah, and thank you very much, Jonathan. And in a sense, Ping An and the good doctor, you were born digital. But maybe if I can turn the time to Jeff, and really for some of your more traditional bricks and mortar businesses, you've had to transform in a very short period of time to go digital. And the last couple of months, really Fullerton had unveiled telehealth applications and so on. Could you share a little about this journey and some of the stumbling blocks as well as some of the successes? Over to you, Jeff.
Sure. Thank you, Jeremy. So interesting enough, I've been at Fullerton since early 2019. So this is, I think Fullerton you can look at as more traditional healthcare services, and then we're going from offline to online. Prior to that, I was the CSO at WeDoctor. So I know it's a competitor to Good Doctor. So that's really an online to offline type of business.
Yeah.
So interestingly, my experience is that healthcare, at least prior to COVID-19, adoption of online where people are willing to pay, or obviously different market. China is very national health insurance driven. Places like Singapore where it's very private insurer driven. So prior to that, the payer adoption has been low, as Jonathan has mentioned. Now China has started to open up. And similarly, in I think Singapore, we're seeing more and more insurance willing to adopt for it because of the demand for it, given COVID-19. And so our strategy, since I joined, has always been, how do we leverage technology, internet, to make our traditional services much more effective, efficient, and eventually more holistic so that I can engage and serve the users not only when they're sick, but even when they're not sick. I can curate content for you. I can provide a wellness program for you, chronic disease management, to make you live healthier. And I think what's interesting, what we have seen is last year before COVID, I would say the demand from clients has always been, yeah, we'll need telemedicine, we'll need virtual, we'll need all these delivery online. Yeah, we'll probably look at it 6 months, a year later, right? It's in the works, it's in the pipeline. And then COVID happens, I would say probably February, March, all of a sudden we say we need that tomorrow type of demand. And I think partly that's due to, as you know, Singapore, very similar to Hong Kong, is you can probably go down the block and every other block you have one primary care clinic. Yeah. So historically, the adoption needs wasn't there. There wasn't a very push factor to say, hey, we have to have this. But with the circuit breaker, with the shutdown, all of a sudden people have no choices or prefer not to go. And all of a sudden the adoption started much quicker. So what you'll see is at Fullerton, what we have introduced is not just a simple COVID symptom checker where you can check whether you potentially could have COVID, but really is to try to integrate the online to the offline experience. So you do the COVID symptom checker. After that, you can actually chat, with the doctor, with a nurse. Then post that as needed, we can integrate you into our offline clinic. So there's that online to online again, kind of the whole journey to make sure it's complete and it's a holistic circle. So I see, that's how I see the service to be integrated for healthcare is especially important with the offline part.
And before we go to Ingrid, Jeff, could you share a little about how you carried the organization and in particular the doctors? Because we as doctors are quite traditional pen and paper type of people. And when you talk about big data and AI, what's at the back of our minds are also audit and performance management. So what were some of the things Fullerton did to help the doctors to come to terms and to really embrace this new era of online to offline and vice versa?
You're 100% correct. And my experience with doctors is that if you tell them to, hey, why don't you sit in front of a computer for 10 hours a day and just do virtual consult? Most will probably tell you, I prefer not. So the way we do it is really, there's a combination of in-clinic consult, and everybody would spend a specific, let's say 1 hour, 2 hours a day. We pick some doctors and then we rotate to do virtual consult. I think that's one. Number two, I think it's important to show through actual data that there's improvement in efficiency and the workflow. So for example, one thing we did was at NTU, we have a Fullerton clinic within NTU out that whole big campus. And then prior to we launched the online platform, the waiting time per patient on average is about 1.5 hours to 2 hours.
Wow, all right.
We launched online digital consultation, digital virtual appointment, as well as symptom collector. So that on average, the waiting time now is 8 minutes for people who use online appointments. And doctor efficiency improves significantly as well, because that initial 1-2 minutes where when you first sit down, doctor asks you, so what's wrong with you today? Oh, you have headache, do you have fever, do you have cough? That's all been collected already prior to even sat down with the doctor. And so the doctor has that info and they can go much more straight into more personalized service, and as well as the time spent can be much more efficient. So just do that, you're starting to see more doctors willing to adopt because do data to actual examples.
Okay, great, thanks. And when I was in medical school, we were really taught between the history and really the examination, you get most of the diagnosis. But in this era, when we cannot examine patients virtually, then point of care diagnostics, the use of machine learning becomes so important. And I think Jonathan gave us a glimpse of what might be in the future. But the real deep scientist is really Ingray. And how much of this is pie in the sky? How much of this is going to come into mainstream use in 3 years, 5 years? And over to you. And you're on mute, Ingray. Thank you. Great.
Thank you, Jeremy. So basically, I think the COVID-19 is a very good opportunities for us to re-examine the definition of healthcare system. So basically, the current healthcare system is more of a medical system. Yes. So most of the time, when we are talking about healthcare system, we are talking about improve the efficiency, the accessibility of good doctors. So what we are trying to do now is we are trying to digitize using different type of devices as well as the molecular profiles to profile the so-called health status of human, so that we can actually track how people's health status are changing over time, so that we can actually precaution people about whether you are going to have the medical events. So the idea of I think one of the direction for a future healthcare system is trying to preserve people in a status of being healthy, rather than how we can deal with the medical issues when people really get some severe symptom. Okay. So let me put the COVID-19 for example. So now we know that there are a lot of people are infected and they have positive antibody tests. So that actually we can see that COVID-19 gave us a very, very wide range of symptoms. Some are really lethal and some are really like mild. So the key for the future governance is not about whether we should knock down or whether we should just live as it is, like the population immunity. So it's all about, can we actually identify people who are susceptible to the COVID-19 when they get affected by SARS-CoV-2. So that's a real scientific question and technology question behind the scene. And if we are not prepared for that, we can always, what we can do is there's outbreak and we are dealing with that. It's not like we have the daily tracking data for the whole community, and we do see some weird data from here and there, and we just actively to get to them. So what we are trying to do, we're collaborating with a lot of community healthcare center, is we don't want people to go for the clinics. We want the clinics go for the people who need clinics. So in that way, we are trying to improve the efficiency of the real, the intelligence of doctors. And we just let the digital healthcare to do most of the things based on the what we call the multidimensional profile, that is not just biophysics and those biochemistry, POCT type of things, as well as all the other genetics, this and that.
But really, Ingray, as we move more and more into multi-dimensional factors, then the explainability becomes harder and harder. And for us as doctors, we do like to tell the patients that this test shows you have this, therefore this is the treatment. But as we move more into almost black box, when the system looks at 1,000 different factors and say, Jonathan, you should go for a CT scan of your heart, right? what do I as the doctor tell really Jonathan? Do I just say that the machine said that you should go for a CT? I'm not sure why, but trust the machine. It hasn't been wrong. So how are we bridging this notion of really explainability?
Yeah. So I think this is very key in the transformation between the previous traditional medical area to the what we call the digitalization or the virtualization of digital healthcare. The key thing is we scientists should not do the work of doctors. So the idea that we are trying to implement here in the pilot testing of the very many communities is about like 400,000 people.
Yes.
So what we do, most of the decision are actually still done by doctors.
Yep.
So the first wave of applying the data is we can pick up the data that could help to support the decision of doctors to support the evidence or whatever the point that he would like to make. And the good thing about all these type of multidimensional tracking data is you can always, because this is a community and you are tracking the people's health status, and you know that their response afterwards. So that you can it's like what we call the real world cohort study, and you can always see the outcome and associated with different type of treatments and what are the reflections on their molecular profile, this and that. So I think the key is we are still coming back to the evidence-based medicine, but we need very strong evidence about the explainability, so that we have to have a very big community and we have to deploy all this infrastructure. And given that big data set, we can have the potential explainability about the so-called big data.
Yeah. Thank you. And this really takes us to the good doctor fundamental model, which is an AI triage layer to help channel patients to the right doctors and to allow doctors to almost have a list of provisional diagnosis, but it's the doctors who then make the confirmations. And Eddie, Jonathan, you had mentioned around reimbursement and how transformational this was. And we discussed earlier about the experience of SARS and how SARS came and went in about 4 months and the world went back to normal. This time around, with advances in really technology, COVID being likely to be with us for a while, what are your recommendations, both you, Jonathan, and Jeff, for healthcare providers to make these transformations sticky and really enduring? What are you guys doing as a community of healthcare providers?
I think that the severity of COVID and the fact that it's a global phenomenon where SARS really wasn't, and the fact that we now have a different generation of technology to work with, in particular the ubiquity of mobile and the computer processing power that just in that mobile device, combined with cloud and all the rest of that. I mean, there are a lot of things that are different, but I think if we just leave it to the traditional medical system to sort itself out, it's just not going to happen. And I don't think that the average cardiovascular surgeon or the average general practitioner who's in sole practice or in partnership has the time, the wherewithal, the infrastructure, or even the knowledge of what it takes to transform their business into a digital model. I think it's interesting when you talk to doctors in light of COVID, and whether it's surgeons or whether it's ENT specialists or GPs, I've been really surprised just in my own sort of contact with people in the medical profession at how open people are, exactly what Jeff said, to exploring how they can use their own time more efficiently, how many doctors recognize that probably 50-60% of the people they see really don't need to be there in person. It's worth mentioning that it's not that we can only see you on a mobile or we can only interact with text. We have ways of we have digital stethoscopes that can plug into a mobile, digital temperature monitors. We have cameras that can look into your throat or your ear. So there actually is quite a lot we can do to simulate an in-person experience. But I think to your question, what is this really going to take? Of course, there will be leading companies like Good Doctor and other players in places like China, or the many players in the United States, like America Well, etc. There'll be companies like Fullerton who take the initiative as traditionally offline providers to actually start building out the digital infrastructure and digital experience. But I do think this is going to require collaboration from the profession, from the health system, and in particular from the government, from payers, as well as both traditional and new generation providers. And this is going to require a fair degree of integrated strategy work, certainly alignment of objectives, and probably inevitably leadership from health authorities.
Okay, great. And Jeff, maybe you could also chime in and take this question around electronic medical records and the notion of data privacy. If we compare ourselves to, say, the financial services industry, banks need to talk to each other, otherwise the system just breaks down. But today, healthcare is really built into very deep silos. And what should we do about it? And how do we safeguard so that people feel completely comfortable sharing their health information, knowing it'll be well taken care of? Jeff, over to you.
Yeah, so I think one of the key interesting things is that if you look historically, and you're right, it's very siloed, right? You go to one hospital, whatever medicine, whatever consultation you have, you go to hospital B, it's no longer there, and you don't remember what medicine you have taken, even if it's very effective. So I think what we really trying to do is take that power back to individual, right? Now the record is no longer siloed into, let's say, one clinic, one hospital. It is really, if you come to Fullerton platform, or you come to our more consumer-focused Live Folder platform, your record is on your hand. So you have all those records. Now, when it comes to data privacy, obviously, I think it's very important that we're not out there saying, hey, we're selling your record to a third party so they can do the analyzation. I think we're doing the analytics ourselves, and it's about showing them that over time, do all these data analytics, how can we make you become healthier? And I think the adoption is not so much of, okay, telemedicine. I see that in terms of telehealth as a bigger piece. Telemedicine is just one piece of it. It's really moving from, okay, now I can start solving your problem, do online or do tele, and then how can I continue to move forward to provide you a holistic yourself in a data perspective, so that I can, instead of just very one-size-fits-all type of wellness program, now it's a very targeted wellness program, because now you have data, your analytics to really tell each person what they need to become healthier, to become living better. I think that's where I see the trend is in terms of how digital online can really help.
All right, thank you. And Jonathan, go ahead.
I think a good telemedicine infrastructure can actually become the backbone of a health system. And to Jeff's point exactly, it could become the locus of individual records that are secure, that are controlled by the individual, that providers have access to when they want to serve you, but also that they contribute to when they do serve you. And if you think about, times 100, 200, 300 million patients over a long period of time, the value of that data, both for the individual patient, but as well for the population, can be absolutely enormous. So I think this has to be the future. But of course, there are many obstacles in the way in which data is stored and indeed hoarded in some cases and not shared in today's infrastructure.
Okay, guys, we have run out of time. So permit me to just very quickly sum up that we are in a very exciting, pivotal point in the transformation of really healthcare. As we move towards digitalization, this creates all the opportunities around use of AI and machine learning, as well as Jeff's point, personalization, and also Ingrid's point around, rather than being reactive as a health system traditionally is, to being proactive, telling people what their risk factors are and how to be healthy for as long as possible. And COVID-19 has been the great driver to catalyze a lot of this. We're only at the beginning. Stay tuned, look out for the organizations that our three panelists belong to. They are at the forefront of change. And on this note, thank you very much. I'll hand the time back to Laura.
Thank you. Thank you so much, Jeremy, Beth, Marie, and Jonathan. Thank you for that session. A virtual round of applause on behalf of all the participants. It's encouraging to hear about the innovations and transformations that are taking place. This is the end of our 11th episode. We are going to stop doing episodes for a little while. I'm going to come back in the summer in July with a new series focused on US, China, and ESG issues. Now, thank you all. Have a good day. Bye-bye.
All right. Thank you, everyone. Bye-bye.